Hello everyone and welcome to our module on antimetabolites. Antimetabolites are chemotherapy drugs used to treat malignancy, and they're called antimetabolites because they block the formation of components or metabolites of DNA. Because they block the synthesis of DNA, they are generally cell cycle specific with just a few exceptions. Most of these drugs have toxic effects in the S phase of the cell cycle when DNA is being synthesized. We'll talk about all of the antimetabolite drugs listed on this slide, but before we can do that, we need to review some biochemistry about how nucleotides and DNA are synthesized. I talk about this in detail in the biochemistry section, but I'll review some of the key points here so that you can understand how these chemotherapy drugs work. DNA and RNA contain nitrogenous bases. Some of these bases have one ring. Those bases are called pyrimidines. I've always remembered this by thinking of a pyramid as a single structure, and therefore the pyrimidines have a single ring. Cytosine is one of the pyrimidines, so is thymine, and so is uracil, and you may know that uracil is found in RNA but not DNA, and thymine is found in DNA but not RNA. There are also nitrogenous bases with two rings. These are called the purines, and those are adenine and guanine. When one of the nitrogenous bases is added to a ribose sugar and a phosphate, it is then called a nucleotide. And there are pyrimidine nucleotides which contain the pyrimidine bases, and there are purine nucleotides which contain the purine bases. And the nucleotides have names which are similar to the base they contain. So for example, cytidine contains cytosine, thymidine contains thymine, and uridine contains uracil. There are also nucleotides called adenosine and guanosine. Note also that if there is a hydroxyl group in this position on the sugar molecule, this molecule is therefore a ribonucleotide. If there is no hydroxyl group in that position, this is a deoxyribonucleotide. Ribonucleotides are used in RNA, and deoxyribonucleotides are used in DNA. And the way deoxynucleotides are synthesized is that the ribonucleotide is synthesized first, and then an enzyme called ribonucleotide reductase removes the hydroxyl group at this position to convert the ribonucleotide shown on the left side of the screen into the deoxyribonucleotide shown on the right side of the screen. So I reviewed all that biochemistry so that we can understand the antimetabolite drugs, and we'll get into the individual drugs in a minute. But first I want to mention a few words about a common side effect of all of the drugs we'll discuss in this module. Drugs in this module disrupt DNA synthesis, and therefore they are going to target rapidly dividing cells. Those are the cells that are highly dependent on DNA synthesis so that they can grow and divide. One group of rapidly dividing cells found in the body are the bone marrow precursor cells. They are always dividing to make more red cells and platelets and white blood cells. For this reason, a common side effect of all the drugs we'll discuss in this module is myelosuppression. Specifically, by disrupting DNA synthesis, these drugs create a megaloblastic anemia, which we'll talk about in a minute, as well as thrombocytopenia and leukopenia. And in clinical practice, when you rotate on oncology wards, you will find that you will monitor for most patients what's known as the absolute neutrophil count, or ANC. When this level gets below 500, that is the definition of neutropenia, and patients who are neutropenic are at very high risk of infections, especially life-threatening bacterial infections, because you need your neutrophils to fight off bacterial infections. The type of anemia caused by the antimetabolite drugs we'll talk about in this module is a megaloblastic anemia. So it is an anemia with a reduced hematocrit. The cells are large, therefore the MCV is increased. That's why it's called megaloblastic. In addition, on a peripheral smear, you can find hypersegmented neutrophils as shown in this example on the screen. Megaloblastic anemias are commonly caused by any process that leads to defective DNA production. The classic examples of causes of a megaloblastic anemia are a vitamin deficiency of B12 or folate. However, this type of anemia also occurs in patients on chemotherapy drugs like methotrexate, 5-FU, or hydroxyurea, all of which we'll talk about in this module. Our first antimetabolite chemotherapy drug is cytarabine, which is also called Ara-C or cytosine arabinoside. Cytarabine is a pyrimidine analog. This is its structure at the bottom left side of the screen, and you can see that it has a very similar chemical structure to deoxycytidine. The difference is that there is a hydroxyl group in this spot in an abnormal position. For this reason, it will mimic the nucleotide cytidine, and when it is incorporated into DNA by DNA polymerase will no longer be able to do its job. So therefore, it inhibits DNA polymerase by mimicking the structure of the pyrimidine cytidine. This drug is only effective in leukemias and lymphomas. Its adverse effects include myelosuppression, which is common to the drugs we'll talk about in this video. In addition, it can cause nausea and vomiting, and this is true of many chemotherapy drugs. And at very high dosages, it can potentially cause neurotoxicity. This often presents as a peripheral neuropathy, confusion, or cerebellar ataxia. Our next drug is clodribine, which also functions by mimicking the effects of nucleotides. In this case, it is a purine analog that mimics adenosine. If you look at the bottom of the screen, clodribine has a very similar chemical structure to adenosine. This makes clodribine highly toxic to lymphocytes, and the high-yield thing to remember about this drug for your exams is that it's a drug of choice in a rare form of leukemia called hairy cell leukemia that I talk about in other videos. Clodribine is special among the antimetabolites. It has effects outside of S phase, and so for that reason it is cell cycle nonspecific, and its main adverse effect is myelosuppression from blocking DNA synthesis in cells of the bone marrow. Our next drug is methotrexate, which mimics the structure of folate. At the bottom left side of the screen is the vitamin folate. Methotrexate is shown on the right side of the screen. You can see that it has a very similar chemical structure. By mimicking folate, it blunts the synthesis of DNA nucleotides, and therefore it indirectly decreases DNA synthesis. Specifically, what methotrexate does is it inhibits dihydrofolate reductase, an enzyme important for folate metabolism. This blocks the synthesis of tetrahydrofolate, and tetrahydrofolate is required for DNA synthesis, but also RNA synthesis and synthesis of some proteins. One of the most important things methotrexate does is block the formation of the nucleotide thymidine, which is necessary for synthesis of DNA. This is a slide from our biochemistry videos showing how thymidine is synthesized. So cells first synthesize deoxyuridine monophosphate, and then there's an enzyme called thymidylate synthase, which converts deoxyuridine monophosphate to thymidine monophosphate. What it does is add a carbon to this position. That is the only difference between the nucleotide thymidine and uridine. In order for thymidylate synthase to carry out this reaction, it requires a cofactor called N5-N10 tetrahydrofolate, and this cofactor is derived from folate in our diet, which is converted to dihydrofolate and then to tetrahydrofolate by the enzyme dihydrofolate reductase. So when methotrexate inhibits the function of this enzyme, it decreases the pool of N5-N10 THF, and that blunts the ability of thymidylate synthase to make thymidine. Methotrexate is used in a number of clinical scenarios because it's highly effective, and also it's available in oral or intravenous forms. So it's used in many malignancies, often as an infusion, including solid tumors and leukemias and lymphomas. It's also used in the oral form for immunosuppression in many autoimmune diseases. It's an example of a steroid-sparing agent. This is a drug that can be used to wean or eliminate the need for long-term steroid use in patients with autoimmune diseases. Long-term steroid use carries a risk for many side effects, so patients are often weaned off of steroids and transitioned to drugs like methotrexate so that they don't need to take the steroids. Methotrexate can also be used to cause a pregnancy abortion, especially in cases of ectopic and tubal pregnancies. Just like many of the drugs in this module, a major side effect is myelosuppression. This is more common with high dosages, especially those used to treat malignancies. The myelosuppression can be reversed by giving a drug called leucovorin, which is folinic acid. Leucovorin is converted to tetrahydrofolate but does not require dihydrofolate reductase. Therefore, it can reverse the myelosuppressive effects of methotrexate. This is called the leucovorin rescue. If we go back to this slide, methotrexate inhibits dihydrofolate reductase. Leucovorin, however, can be converted to tetrahydrofolate without need for the enzyme dihydrofolate reductase. This can restore the pool inside of cells of N5-N10 tetrahydrofolate, and it can allow thymidylate synthase to begin synthesizing thymidine again. Methotrexate can also cause mucositis, which is mouth soreness. This occurs with many chemotherapy agents, but it's particularly common with methotrexate. This occurs because the drug damages the GI epithelium and there's loss of the mucosal integrity. This leads to pain and bacterial growth. And when you rotate on chemotherapy wards in the hospital, treatment of mucositis is a major issue for many patients. In addition, methotrexate can also potentially cause hepatitis and abnormal LFTs. It can also cause GI upset, just like many chemotherapy drugs. In rare cases, methotrexate can cause what's known as methotrexate-induced lung injury. This usually occurs in patients taking low-dose therapy for weeks or months for immunosuppression. In most cases, it's believed to be a hypersensitivity reaction. There is evidence of lymphocytes and eosinophils that can be found in the lungs. If left untreated, it can potentially progress to pulmonary fibrosis, like what's shown in this X-ray on the screen here. And for that reason, you'll read in some review books that methotrexate can cause pulmonary fibrosis. Usually it doesn't get to this point, and usually the lung symptoms resolve on discontinuation of the drug. Our next drug is 5-fluorouracil, which is also called 5-FU. This drug mimics the structure of the nitrogenous base uracil, which is a pyrimidine. The top right side of the screen is the chemical structure of uracil. 5-FU has the same structure but for a fluorine added in the 5 position. That's why it's called 5-FU. In cells in the body, it's converted to 5-fluorodeoxyuridine monophosphate, which is a mutant or abnormal form of uridine monophosphate. In this form, it will inhibit the enzyme thymidylate synthase and block the formation of thymidine. Thus, cells are said to undergo a thymin-less death. And in contrast to methotrexate, the effects of 5-FU are enhanced, not reversed, by leucovorin. If we go back to this slide, 5-FU forms a mutant form of uridine monophosphate which inhibits thymidylate synthase. Thus, cells cannot synthesize thymidine and they undergo a thymin-less death. Now, in the case of methotrexate, when leucovorin is administered, it replenishes THF levels and allows this process to begin again so that more thymidine can be synthesized. That's why leucovorin works to rescue or reverse the effects of methotrexate. In the case of 5-FU, however, leucovorin is going to make this whole process go faster so that thymidylate synthase more quickly binds the mutant forms of deoxyuridine monophosphate. This will lead to faster and more significant inhibition of the enzyme thymidylate synthase, and thus it will enhance the effects of 5-FU. 5-FU is one of the major drugs used in the treatment of colorectal cancer. It's also used in some other solid tumors like breast cancer and pancreatic cancer. It can also be used topically as therapy for basal cell skin cancer. The adverse effects are many of the usual adverse effects of chemotherapy agents. This includes myelosuppression, nausea, vomiting, diarrhea, and mucositis. These problems can be seen with many other chemotherapy drugs. Two special side effects are CNS side effects like cerebellar ataxia and encephalopathy. This is a rare complication of 5-FU. And finally, in my field of cardiology, 5-FU is kind of famous because it can potentially cause coronary vasospasm. This can lead to angina and EKG changes. Our next drug is 6-mercaptopurine, and this mimics the structure of the purine bases hypoxanthine and guanines. And if you forget that, it's got the word purine in the name of the drug to remind you. If you look at the bottom left side of the screen, shown is the structure of hypoxanthine. Hypoxanthine is a nitrogenous base. It is not found in DNA or RNA. It is an intermediate in synthesis of the purines guanine and adenine. Shown at the right side of the screen is the nitrogenous base guanine. You can see that 6-MP looks similar to these two nitrogenous bases. It has a sulfur moiety where they both have an oxygen moiety. 6-MP will be added to a chemical structure called PRPP by an enzyme called HGPRT. I'll show you this on the next slide. And this will form a mutant form of a purine called thiocinic acid. This will inhibit multiple steps in the purine salvage pathway and lead to a decrease in cellular levels of inosine monophosphate as well as adenosine monophosphate and guanosine monophosphate. PRPP has a structure which looks like a nucleotide missing a base, and the enzyme HGPRT, which stands for hypoxanthine guanine phosphoribosol transferase, can add a base to PRPP. If it adds a guanine to PRPP, it will create a molecule of guanine monophosphate. If it adds hypoxanthine, it will create the nucleotide inosine monophosphate, which is an intermediate that can then be converted to either GMP or AMP. What 6-MP will do is get picked up by HGPRT and added to PRPP. Thus, it is mimicking the structure of hypoxanthine or guanine. When it does this, it creates a mutant nucleotide which can then inhibit DNA synthesis. Closely related to the drug 6-MP is the drug azathioprine. Azathioprine is a prodrug. It is converted by the body to 6-MP and then exerts the same effects on cells. Shown at the bottom left side of the screen is the chemical structure of azathioprine. If this portion of the molecule is lopped off, you will have the chemical structure of 6-MP, which can then go on and do the same things that we showed 6-MP doing on the last two slides. Azathioprine and 6-MP are usually not used as chemotherapy agents. They are used for immunosuppression. Just like methotrexate, they are steroid-sparing agents that can be used to wean patients off of steroids. They're often used in inflammatory bowel disease. They can be used to prevent rejection in solid organ transplant patients. They're also used in many other autoimmune diseases. The major adverse effects of these drugs are nothing special. They can cause myelosuppression, they can cause abnormal LFTs, and they can also cause GI upset. There is an enzyme in the body that's very important for the metabolism of 6-MP and azathioprine, and that enzyme is called xanthine oxidase. This is a purine metabolism enzyme that converts xanthine into uric acid. Shown at the bottom left side of the screen is the structure of xanthine. It's converted by this enzyme into uric acid. This enzyme is inhibited by allopurinol and febuzistat, both of which are used for gout. In gout, you want to decrease uric acid levels so using these two drugs to inhibit xanthine oxidase is beneficial. Azathioprine and 6-MP are also metabolized by xanthine oxidase. The enzyme converts 6-MP to an inactive metabolite called 6-thiouric acid. What this means is if you administer allopurinol or febuzostat to a patient also taking azathioprine or 6-MP, you will blunt the breakdown of the drug. This can potentially cause more adverse effects. This is also sometimes done on purpose to boost the effects of azathioprine or 6-MP. There is another drug called 6-thioguanine that also mimics the bases hypoxanthine and guanine, the purines. This is the structure of guanine at the bottom left side of the screen. 6-thioguanine has a sulfur atom instead of an oxygen atom. It has a similar mechanism to 6-mercaptopurine. It will decrease cellular levels of IMP, AMP, and GMP, and therefore inhibit DNA synthesis. The last drug I'll discuss is hydroxyurea. This is its structure shown on the screen. It does not mimic a nitrogenous base or a nucleotide. Hydroxyurea works by inhibiting the enzyme ribonucleotide reductase, and at the beginning of this video I mentioned that this enzyme converts ribonucleotides into deoxyribonucleotides. So when ribonucleotide reductase is inhibited, this will block the formation of deoxynucleotides and therefore block DNA synthesis. One of the advantages of this drug is that it has good oral bioavailability, so it can be used as a PO drug, and its major adverse effect is myelosuppression, just like many of the other drugs in this module. Hydroxyurea is rarely used for malignancy. Its two major uses are in myeloproliferative disorders and sickle cell anemia. In the myeloproliferative disorders polycythemia vera and essential thrombocytosis, hydroxyurea can be used because it's effective at reducing either the red cell count or the platelet count. It's used in sickle cell anemia for a reason that has nothing to do with inhibition of ribonucleotide reductase. Hydroxyurea can increase fetal hemoglobin levels. The mechanism of this effect is unclear, and for this reason it's beneficial in sickle cell patients. So I'll finish with this summary slide. What you want to remember for step 1 is that all of these drugs inhibit DNA synthesis, and you want to remember the mechanism by which they do this. So methotrexate does this by mimicking folate. We talked about a number of drugs which mimic the purines. Remember, the purines are the nitrogenous bases with 2 rings. We also talked about some drugs which mimic the pyrimidines, which have 1 ring. And then finally, we talked about hydroxyurea, which has a unique mechanism. And that concludes our module on antimetabolites.